The following program is an educational service of Ross Laboratories, developed in cooperation and coordination with the American Academy of Pediatrics. Pediatrics in Review.
I don't know, maybe he's just having bad dreams or something, but he kind of turns white and then he tenses up and then he shakes his arms up and down and I don't know, it's almost as though sometimes he just stops breathing. I don't know, it's scaring me half to death.
It's probably just nightmares.
Well, I can certainly understand why you're concerned.
Sudden unusual movements in children can be a nightmare for parents, not knowing if these are normal movements or something far more serious. With the mere mention of the word seizure, parents become anxious about their child's general safety, their success at school, and even their ability to drive or be gainfully employed in the future. Will a diagnosis of seizures mean that their child will be subject to a lifetime of testing and medication? As a pediatrician, you know that a quick and accurate diagnosis can save the patient and his family years of frustration and worry. And an early diagnosis can also greatly increase the chances of successfully controlling seizures, preventing conditions like status epilepticus from ever occurring. With this presentation, we will show you typical examples of seizure and movement disorders that you may encounter in your training or office practice. It is our hope that through these examples, we might expand your awareness of these disorders in both infants and children.
She seemed afraid.
A careful clinical evaluation is the first step to an accurate diagnosis.
Not that I noticed. I don't know if you've seen any.
Real quiet. Play quietly.
When evaluating a child with abnormal movements, a complete, detailed, and careful physical and neurological examination are crucial. During the clinical evaluation, it is important to remember that most seizures or movement disorders are associated with specific age groups. If the history or the physical examination suggests specific causes, further laboratory tests such as serum chemistries could be performed. Where is it now? Lucy, where is it now? Where is it now? In specific cases involving partial or focal seizures, computerized tomography or the newer magnetic resonance imaging would be indicated. In the evaluation of any child suspected of having had a seizure, the electroencephalogram, or EEG, is an essential diagnostic tool. It's important to remember, however, that not all EEG abnormalities indicate that a child has had a seizure or has epilepsy. Another important point is that some children with seizures or seizure disorders may have normal EEGs between their clinical events.
The best way to accurately diagnose seizure disorders is to witness a clinical event. In cases where the diagnosis is unclear and the history incomplete or confusing, simultaneous EEG video monitoring can provide the basis for an accurate diagnosis. As these videotape examples will demonstrate, there are certain types of observable movements which characterize each specific seizure type. Neonatal seizures can be seen as early as minutes after birth, although most occur within the first week of life. This full-term infant is exhibiting the regular rhythmic jerking movements of clonic seizures. Clonic seizures in the neonate have features which differ from those of older infants and children. For example, notice the migration from arm to shoulder to face, and eventually to the right leg. Another feature of neonatal clonic seizures is the independent asynchronous movements of the arms and legs. This jittery newborn has benign tremors, which are not seizures. Although they may look similar, tremors should not be confused with clonic seizures. As shown here, tremors can be arrested with simple restraint, whereas clonic seizures cannot be suppressed in this way. Another important seizure type seen in neonates is tonic seizures, which can include sustained extension of the limbs, such as seen in this infant, flexion, or mixed posturing. Motor automatisms, or subtle seizures, are another type of neonatal seizures. They can be chewing or sucking motions, such as seen in this infant, or irregular eye movement, such as seen here. Notice the convergence, deviation to the left, followed by deviation to the right, and nystagmus. Or the bicycling or pedaling motion of this newborn's lower extremities. Infantile spasms are seen in patients from the neonatal period to about 16 to 18 months and tend to peak at about 6 months. It is important to differentiate infantile spasms from other seizure types in infancy because they require hormonal rather than standard anticonvulsant therapy. Some spasms may appear as rapid, repetitive flexion of the extremities and trunk, while other spasms may be predominantly extensor, as in this infant. Still other infants may demonstrate mixed flexor-extensor spasms. An EEG of children with infantile spasms typically shows a disorganized background with high-voltage slow waves and asynchronous multifocal spikes. This pattern is known as hypsarrhythmia. Many of the seizure types seen in later childhood can also occur in infancy. For example, some infants may have generalized tonic-clonic or clonic seizures, which are readily diagnosed as such. However, some types of movement may be more difficult to recognize as seizures. Rapid twitching of the eyes is often quite alarming to parents who witness it in their child during sleep. It can be characteristic of REM sleep, or rapid eye movement, or can be indicative of other non-seizure conditions, such as tics. However, the rapid sustained twitching of this baby is a clinical seizure. Likewise, the irregular eye movement and facial twitching of this infant is also a clinical seizure. The sudden violent jerking of this 1-year-old infant is characteristic of myoclonus. Myoclonus can occur as isolated seizure activity or can be associated with other seizure types. It can be seen as early as the neonatal period and then throughout childhood. It is important to note that some myoclonus may be benign, as with this sleeping 2-year-old. Atonic seizures are usually seen in children who are a little older, most often from the ages of 2 to 10 years old. Atonic seizures are characterized by a sudden loss of postural tone without a loss of consciousness. Notice how this little girl suddenly drops her toy and struggles to remain standing after each brief loss of postural tone. In some atonic seizures, this sudden loss of tone can cause children to suddenly fall to the ground and possibly injure themselves. Between 2 to 5% of all children will experience a seizure with fever before age 5. The most common type is benign febrile seizures.
What do you mean by shaking? Describe that to me. Is he shaking all over, or is just one part of his body shaking?
Well, he's kind of tremors.
These seizures are brief, generalized clonic or tonic-clonic convulsions, not associated with central nervous system infection. They can be quite upsetting to parents, although they usually have no residual effects on the child. Careful questioning during the history can help distinguish benign febrile seizures from complex febrile seizures, which may suggest more serious problems.
I come and pick him up because it's frightened me so much that he's having this difficulty.
And then how long does that last when you
First,
get in and pick
try
him up?
to
How long does
determine
that
if the
shake
seizure
last?
occurred early in the course of the fever. Benign febrile seizures typically occur early. Seizures which begin after the first 24 hours of febrile illness may suggest other problems, including central nervous system infection. You need to find out what type of seizure it was. Benign febrile seizures are generalized clonic or tonic-clonic seizures rather than focal.
Have those changed at all?
Was the seizure long or short? Benign febrile seizures are usually short in duration, lasting less than 15 to 20 minutes.
I haven't noticed that. Okay. complaining about? Is your throat sore, Dante?
A follow-up neurological exam of a child with a benign febrile seizure would indicate no focal signs. However, if you see transient unilateral weakness of the limbs, known as Todd's paralysis, immediately after the seizure, the child most likely had a complex rather than a benign febrile seizure. In addition, a follow-up EEG done 10 to 14 days postictally should be normal.
As we have seen, neonatal seizures and infantile spasms predominate in the first 6 months of life, whereas simple febrile seizures are the most common seizures seen in children after infancy. Akinetic and atonic seizures are fairly uncommon and are usually seen in children just prior to their entering school. Let's move on now to look at the seizure and movement disorders more common to school-age children.
His teacher says that sometimes he just sits and stares, as if he's on another planet. Ugh, he just can't seem to pay attention. And sometimes I'll call him and he won't come, and I'll get so mad and go into his bedroom, and he'll say he didn't hear me.
I told you I didn't
now,
hear you.
Now, I know he heard me.
I told you I didn't hear you.
Absence, generalized tonic-clonic, and partial seizures all become more prominent in the school-age years. Daytime seizures may interfere with school performance, and some may initially be confused with various movement, syncopal, or behavioral disorders. Nocturnal seizures may interfere with sleep and can be confused with some sleep disorders. While the differential diagnosis of unusual behaviors is broader in this age group, history taking becomes a bit easier because older children may be able to describe how they felt before and after the seizure. As Dr. Gerald Golden explains, there are 3 basic areas of questioning any history should address when seizures are suspected.
3 basic areas of questioning concern the preictal phase, the ictal phase, and the postictal phase. The most important feature of the preictal phase is whether or not an aura was present. If so, it indicates that the seizure had a focal onset. In the preictal phase, we are also concerned as to whether there are environmental precipitants that regularly cause a seizure. These could include loud noises, blinking lights, or a sudden fright. Analysis of the ictal phase has 4 important components. First, was there loss of postural tone? Second, were abnormal movements present? Third, did the child lose contact with the environment? And fourth, were there associated signs such as loss of bowel or bladder function or autonomic abnormalities? The postictal phase is monitored by how long it takes the child to regain consciousness. An important feature of this phase is whether or not focal neurologic signs were present. It is obvious that the child can give information about the preictal phase, but would be unable to tell you what occurred during the seizure or during the early part of the postictal phase until consciousness is fully regained. The child's parents, babysitters, teachers, or other significant adults in the environment can be excellent sources of information concerning what actually occurred during the seizure.
If the onset of seizures coincides with other significant trauma in the child's life, such as separation or divorce of parents, a move, or trouble coping in school, sudden lapses of attention may be viewed as simple daydreaming or escapism, and what are actually automatisms associated with seizures may be mistaken for simple nervous tics or mannerisms.
In consideration of a child with sudden alteration of consciousness, absence seizures must be differentiated from complex partial seizures. Both have different therapy and prognosis. As we've seen, absence seizures have abrupt onset, they're relatively short in duration, with a sudden termination of the clinical event, with the child returning to normal. On the other hand, complex partial seizures typically have an aura which precedes a clinical event. The event may be somewhat more prolonged, and the termination of the event more gradual. There is also, following the event, typically some confusion. Other features of complex partial seizures include activation of the autonomic nervous system, manifested by such signs as drooling, salivation, flushing, or pallor. Finally, there are also unusual features such as inappropriate stereotypic behaviors.
Absence seizures, referred to in the past as petit mal, can be frustrating to parents, teachers, and children. And because duration is brief, recovery almost immediate, and often there is no loss of postural tone, they can go completely undetected or be misdiagnosed. This 9-year-old girl has been instructed to count aloud. Notice the sudden arrest of behavior in conjunction with typical 3 per second spike and wave activity on the EEG. Notice the automatisms, picking at the clothes, nails. If you tried to speak to her, she could neither speak nor understand. At the conclusion of the seizure, she resumes counting and has no recollection of the seizure.
34, 35.
Complex partial seizures also include alteration of consciousness and automatisms. But the gradual appearance of other subtle clinical signs helps to differentiate complex partial from absence seizures. This child begins fumbling with the harmonica she was using at the seizure onset. She demonstrates slight chewing motions and has a slight pallor. Notice the scared look on her face. Affective states can be part of complex partial seizures. Patients may appear to experience sadness, joy, anger, or fear. In addition, patients with complex partial seizures can have hallucinations with a full visual and auditory component. This patient's affect may be in response to this type of hallucination. Other seizure manifestations may take the form of crying out, laughing, swearing, or making unusual noises, as in this instance. Complex partial seizures, as well as other seizure types, can also occur in sleep. It is the eye-opening and arousal which distinguishes this as a seizure. The problem here is that this kind of night seizure can resemble a common childhood sleep disorder, pavor nocturnus, or night terrors. This child with night terrors exhibits similar thrashing, but does not display the same eye-opening as in the previous example.
In simple partial seizures, there is no alteration or loss of consciousness. Most simple partial seizures are characterized by rhythmic jerking or twitching of the arm or leg or of the face. An important epileptic syndrome of childhood, characterized by simple partial seizures, is benign Rolandic or Sylvian epilepsy. Typically, this syndrome occurs in children from age 2 to 14 years who are neurologically and intellectually normal. This syndrome represents up to 25% of epilepsy in school-age children. There is typically, or usually, a spontaneous resolution of the syndrome.
This 15-year-old girl is having a simple partial seizure. She is awake and alert, yet displays sustained eye deviation and posturing of the arm. What distinguishes this child's perioral movements as a simple partial seizure is its sustained rhythmic character. If this were a simple tic, the movement would be intermittent and irregular. Generalized tonic-clonic seizures, also known as grand mal seizures, can sometimes be seen in infancy, but are more generally seen in school-age children. This 13-year-old boy is displaying what most of the lay public would recognize as seizure activity, a typical generalized tonic-clonic seizure. These are characterized by an immediate loss of consciousness with 2 phases of the seizure, a sudden stiffening or tonic phase, followed by a clonic phase. These seizures usually last from 2 to 5 minutes, but may last longer. Typically, there are post-ictal symptoms, which may include lethargy, headache, or muscle soreness. As children move into their teens, they can often develop many types of mannerisms, twiddling their hair, sniffing, throat clearing. Some of these movements may actually be tics or other movement disorders. Simple tics are usually brief and involve isolated muscle groups, whereas complex tics are well coordinated and can resemble voluntary movements, such as we saw with the previous patient's behavior. When tics first appear, it is impossible to determine whether they will be transient or chronic. If chronic, they may remain simple tics or may evolve into the more complex group of tics known as Tourette syndrome. Tourette syndrome represents a specific spectrum of tics within a continuum between simple transient tics on one end and chronic multifocal tics on the other. It generally appears in males with a family history from about the age of 2 to about age 15, peaking at about age 8. The syndrome typically begins as simple tics and within a few weeks can become a repertory of tics. These tics can remain fixed at any stage or change to a different repertory of tics. What distinguishes Tourette syndrome from tics are these vocal tics. One specific type of vocal tic, coprolalia, or the shouting of obscenities, is commonly linked with Tourette's. While these tics can be classified as Tourette's, other non-speech tics such as grunts, squeals, and throat clearing are much more common. For this reason, many Tourette patients are initially referred to otolaryngologists.
Jeff has always been real active, unable to sit still. He was tested at a very early age, maybe 3, for hyperactivity, and he was not hyperactive. As it progressed, we started noticing little tics, I guess, habits he could not control. Maybe 3 years ago was at the earliest that we noticed these things. Toward the end of the 4th grade, one of his teachers, I think it was your speech teacher, mentioned that she had heard of Tourette syndrome and thought that it was possible he had Tourette's and suggested that we go to the doctor and have him checked out. And he said no, Jeff was fine. He's just an active little boy. He's full of energy. He's on the go and no problem. It was another year later that his teachers and principal at Tice Elementary called Jeff's dad and I in for a consultation. Another student at Tice had been diagnosed as having Tourette's, and the child's mother had brought a brochure in. She had read through the symptoms listed on the brochure and said, "Doesn't this describe Jeff?" And it did. It described him to a T, the way his habits.
Although Tourette syndrome is well known and has been widely reported in the medical literature, in approximately 85% of cases, the diagnosis is first suspected or made by the patient, a member of the patient's family, or some of the patient's friends. They have obtained their information from the lay literature or from TV shows that have been produced on the subject. Even if the patient is sent to a physician for attempts at diagnosis, they are often told that the problem is psychological. At that time, they are told that the treatment is psychiatric or may be given the advice that the symptoms should be ignored because calling the child's attention to them would only make them more resistant to later treatment. It is easy to see how this behavior would appear to be psychologically aberrant. Patients with Tourette's can truly suffer psychologically by being unable to control such bizarre behaviors as shrieking, swearing, and even making animal sounds. These vocal tics may be part of a severe case of this movement disorder. Of special note to pediatricians is a warning against the use of psychoactive drugs with patients who may potentially have Tourette syndrome. Many children in the initial stages of Tourette's are diagnosed as having attention deficit disorders, and psychostimulant drugs are prescribed. These drugs can greatly exacerbate Tourette syndrome, accelerating the progress of the disorder, even to the point of bringing on a full-blown case of Tourette's within a matter of a few weeks. Therefore, it is crucial that a careful history of tics and other movement disorders be obtained for any child being treated with stimulant drugs, and that the child be subsequently monitored for the development of tics. Medication should be discontinued immediately if any tic disorders develop.
This concludes our presentation on seizure and movement disorders in children. We hope that by sharing this actual video footage, you will be better able to recognize many of the seizure and movement disorders seen in children.